Shall I go ahead?
No, just a minute. I
Okay.
will allow some people to join because it takes them a minute or so to join.
That
And
makes
then-
so much sense. I just wanted to make sure you weren't waiting.
yeah. I was checking the number of people who are joining. So, and usually I start my introduction very slowly to allow people to join. Okay, let's get started then. Good morning, good afternoon, and good evening, everyone. Welcome to our lecture today on advances towards supporting mental health in the autistic community, a focus on depression by Dr. Catherine Gotham. My name is Antonio Harden. I'm the director of the child psychiatry here at Stanford. As some of you might know, we've been working on different projects to support families in Ukraine. This effort started in late October, and we've had a series of lectures over the last 4 or 5 months. The topics cover issues related to children with autism, but also we have expanded the focus or the scope, and now we're covering topics related to pediatric mental health. Just to give you an idea about the topics that are coming up, on August 24, we have a lecture on attention deficit hyperactivity disorder by Dr. John Lakoff. On September 7, we have a lecture on restricted and repetitive behaviors by Dr. Jackie Rogers and Mirko Oljarevic. And on September 21st, we have parenting strategies to address challenging behaviors in autism spectrum disorder by Karen Beers. In October, we're having a training on the CARS, the Childhood Autism Rating Scale, and it will be done on the 1st and the 3rd Wednesday of the month by Dr. Cheryl Kleinman. I would like to welcome everyone and thank you for attending today. This work is being done in collaboration with 2 organizations, Child with Future, and most recently with Project Hope. And as mentioned, we have a list of seminars, but also we are having a toy drive. All this information is available on our website, and Christelle will put the website in the chat. If you have any questions, please use the question and answer function, and we'll get to these questions at the end of the presentation. Also, we will put a link for a survey for everyone to provide feedback. Your input is critical for us to identify additional topics, and more importantly, provide feedback to the presenters on the content. And now I would like to introduce Dr. Catherine Gotham, who is an assistant professor at the Rowan University. She obtained her bachelor degree in English language and literature at the University of Michigan and obtained her PhD also at the University of Michigan, and completed a postdoctoral research in development of psychopathology from brain and behavior science to intervention at Vanderbilt University. She will be presenting today, as I mentioned, on depression in children with autism, or in individuals with autism in general. Very good. And without further ado, Dr. Gotham.
Thank you so much. And thank you all. This is really, I can't tell you what an honor and privilege this is for me to be here today. So I really appreciate and give my thanks both to the Stanford team and to the Ukrainian team and to the audience. So thank you very much. I'm going to be talking today about supporting mental health in the autistic community. I will try to veer toward more clinical considerations and sort of family level considerations. But as we have time, I may also share some new updates from our research as well. Let's see here. There we go. So I am joining you today, as Dr. Hardin said, from Rowan University. This is in New Jersey on the East Coast of the United States, close to Philadelphia. One of my primary research interests is understanding the mechanisms or pathways by which people with autism become depressed, in the hope that that can shape how we go about treating depression in this population. And that is definitely what we'll talk about today. I just want to present what we know about how common depression is in the autistic community, why it's bad, what it looks like in autistic people, what are some challenges for assessing it. Again, as we have time, what may be some pathways or mechanisms by which it develops. And here, again, maybe after in the Q&A, we can even talk more about specific updates from our research. But I want to really make sure we have time for how people think we should treat it or intervene, and also leave time for, kind of where do we go next, and have a, hopefully get some meaningful discussion around that as well. So starting with background. In a recent meta-analysis, people with autism spectrum disorder were found to be about 4 times more likely to experience depression compared to the general population when pooled across age ranges. And with the underlines here, these are the things that were associated with significantly elevated lifetime depression rates among these pooled samples with autism. Being an adult, which is fairly yes, your life, as you have a longer lifetime, that is associated with, higher chance of having depression within your lifetime. So that makes sense in some ways. But we also are wondering if the process of becoming an adult and adult life as a person on the spectrum also may be in and of itself associated with increased point prevalence, or how common depression is right at that moment for anyone. So increasing age or being an adult, higher measured IQ. I have thoughts on that we're not going to get into today, but the bottom line is we're not really sure if that's a measurement issue, or if if depressed mood is actually more common in people with above average IQ, or sorry, average to above average IQ. Lifetime rates were also associated with using structured interviews versus less in-depth methods of asking people about their depressive symptoms, and associated with self-report versus other report. So when you take a look at these rates, these are really high. And not only is depression prevalent, it's also bad, right? Outside of the context of autism, depression is one of the greatest global contributors to lost functions. So to sort of loss of functioning, which is measured in lost person days. Within the autism community, depression is associated with lots of different areas of impairment, and you can see some bullets here outlining some of those. It also adds significantly beyond existing functional impairments. So where there are deficits in skills associated with autism, having depression can worsen those. And jumping down to this bottom bullet, it also, we have some data to suggest that autism interventions and supports work less well when people are depressed. And then back to the middle here, depression and autism is also associated with greater service use, medication use, greater risk of suicide, or serious health complications. So not only is it common, it's impactful, it's bad news. And finally, as background, depression is repeatedly identified by the autism community as high need, high priority for more services and more research. So in autism, depression is common. Just to sort of sum this background up, depression is common, highly impactful, and identified as a priority problem by the autistic community itself. So what does depression look like in people with autism? Is it different from depression in the general population? So this is what we think so far. People with autism, and sorry, just a note on wording, we often use autistic adults. We use sort of what we call identity first language, autistic adults, when we're talking about the adult population. That seems to be preferred for the adult population. And often families prefer person first, a child with autism. So I'm kind of using both interchangeably, and my apologies, it is not my, definitely not my intention to offend anyone on sort of either side of that. So I'm just going to kind of go back and forth. This is what we think about how depression might look in people with autism. They can experience some or all of these same traditional features of depression. This includes things like sadness, increased crying or feeling of emptiness or loss of pleasure in things that you used to like or love, changes in appetite and sleeping patterns, increased social withdrawal, lack of motivation, and cognitive symptoms like negative thoughts about oneself, feelings of guilt, failure, hopelessness. So these are all sort of traditional there in our manuals for diagnosis, the DSM or the ICD. And in addition to these traditional, beyond these traditional symptoms of depression, autistic people may be more likely to experience some atypical or autism-specific symptoms of depression. And we think that might be changes to the quality or intensity of their special interests, or possibly increased aggression or self-injury. And we actually have, sorry, but yes, this bullet is important. Overall, the presentation of depression and autism seems to look more similar to the general population than it does look different. And that is important to know when we talk about treatment. We found evidence for some sort of autism-specific aspects of depression in a qualitative study led by Gloria Hahn and Jessica Schwartzman. These are two early career researchers who are affiliated with our lab. And our team coded transcripts from structured diagnostic interviews for depression in 21 autistic adults who met criteria for both autism and current depression diagnoses. Sorry, excuse me. And from our thematic analysis of these qualitative data, so what the adults told us in their own words, when we analyzed those, we did find common typical symptoms of depression: loss of motivation, withdrawal, suicidal ideation, rumination, or sort of a passive, negative, repetitive thinking. Excuse me. We also found, atypical descriptions of depression we found them primarily in the form of unconventional metaphors, ways of talking about or describing one's emotional symptoms, or difficulty describing emotional experiences, or significantly increased or decreased interaction with those strong interests. Also, we found pretty frequent mention of some themes that were not specifically depression symptoms, not some symptoms themselves per se, but likely represent risk factors for developing depression. And that included transition to adulthood, and social difficulties and sort of self-identity, self-acceptance of autism as an identity. So that is really what we know about the presentation of depression in autism based on data. Hypothetically, when I think about it, this is sort of what it looks like to me in a lot of cases. Here are sort of these hypothetical, so not based on a single case, but just lots of clinical experiences across multiple people, sort of snapshots of depression in autistic youth. The first one, if I were to describe a socially motivated autistic youth with average intelligence, and then in the context of having a heavy workload at school, So a specific social failure, or sort of a building up accumulation of what is perceived as social failure, loneliness, and anxiety. And then we might start to see symptoms like increased irritability, loss of pleasure in activities, which we'd call anhedonia, or sort of a withdrawal from social or other formerly pleasurable activities, changes to sleep and appetite, negative thoughts about themselves, increases in some autistic features like more intense interests or increased rigidity. In a minimally verbal youth with autism and intellectual disability, again, here for context, hypothetically, we might see a difficult transition or a negative life event. And then you might see symptoms such as increased crying or self-injury, aggression. Doesn't have to be, this is hypothetical, but that is something we've noticed. Increased perseveration, weight gain or weight loss, and then regression in self-help skills, such as, for example, toileting accidents. So this might give you an example, and you can see just from these hypothetical examples how, yes, this, if these symptoms of depression were put onto sort of the existing landscape of a child with autism, you can see how there would be this increased impairment in these young people's lives. But it can be really hard to assess for depression in autism, and assessing it and noticing it and diagnosing it is sort of the first step to getting help or trying to change things. So why is it hard to assess for depression? First of all, healthcare professionals may not even notice it. And if there are sort of lots of symptoms going on, behavioral symptoms, emotional symptoms, they may, by many professionals, just be attributed all to autism. Also, depression itself is known as an internalizing disorder. And it tends to be more challenging for people on the spectrum to identify and communicate about these internal experiences, particularly if they are emotional in nature. Now, I want to say, not for all people on the spectrum, of course. There's a lot of heterogeneity, a lot of variability on the spectrum, and many people have no problems at all sort of identifying and communicating about their emotional states, but some do. And where they do have that difficulty, that often intersects with the high rates of alexithymia in autism, or sort of a condition known for difficulty recognizing or labeling emotions. Also, we don't have a great idea about what signs to even look for in people on the spectrum who use limited or no language, or might be in sort of the moderate intellectual disability ranges, moderate or greater intellectual disability. So there are these specific challenges, many actually specific challenges in assessing depression and ASD. And you don't think of autism and depression being similar disorders, or at least I did not think of that before I started meeting a lot of people with autism and depression. You don't think of those two conditions having similar presentations, or do you? I didn't. But I'm showing this Venn diagram to show this, to hone in on this particular overlap. Imagine you are a clinician who is meeting someone who has poor eye contact, social withdrawal, low motivation, may seem irritable, difficulties with attention or concentration, problems with eating and sleeping, and repetitive thinking. So was I describing a person with autism, or a person with depression, or a person with both? From that pretty extensive list of symptoms, it's impossible to tell. So that really gets us to this quandary. Now, oops, sorry, let me see if I can advance. And that's empirically supported too. People with depression as a group score high on tools to measure autism symptoms, and people with autism as a group tend to score high on depression measures. Then another challenge to measuring depressive symptoms is that we have mixed evidence for the reliability of self-report about internal states. So I'll say that again, that's a lot. We have mixed evidence, so we don't have a clear picture in the literature about the reliability of self-report on internal states within the autistic community. So when self-report and caregiver report sort of diverge in two directions, it may be hard to know, as a clinician, it may be hard to know what to do with that. However, evidence suggests that the role of self-report is significant and makes a statistically significant contribution to identifying depression in people with autism. Okay, so here are some tips that could make our assessment of depressive symptoms more effective when we work with people on the spectrum. First of all, look for symptoms that are new or that are a clear change from that person's baseline. Ask about that when you're talking to family members or caregivers. Ask about changes from baseline specifically. Be open to unusual wording or description of symptoms. So for example, I was trapped in the bleak landscape of a video game. You know, there's kind of this metaphor used for, and we don't think of people with autism being a group that tends to use metaphor, but that is exactly what we found. These atypical or sort of atypical sounds kind of loaded, but these sort of different types of descriptions of internal states that we weren't maybe used to or looking for. Again, include self-report whenever possible, and screen for other physical and mental health issues that are known to be related to depression and ASD, like anxiety, GI problems, gastrointestinal problems, seizures, etc. And finally, as a clinician, as a healthcare professional, screen for suicidal thinking or behavior at every visit, so that it's not the kind of thing that always comes up and comes handed to you on a platter in your face. A lot of times we need to ask about it and then are surprised that this is someone we weren't expecting, we weren't going to ask about it. When we do ask about it routinely, often we hear about it. Okay, going back to our agenda, let's move on from sort of the background and then talking about presentation and assessment, and move on to causes and contributors. Here we're going to talk about how we can use what we know about the development of depression in the general population and apply that to how we think about depression and autism, and then vice versa. On the other side, we can take what we know about autism and inform what we should prioritize looking for among those symptoms or contributors to depression that we know of from the general population. Okay, whoops, do I not have a, there we go. In terms of contributing or causal mechanisms to developing depression, here on this slide, there are just some out of many correlates or contributors to depression that have been identified in the general scientific literature on depression, so not autism specific, but the general literature, that have also been noted in autistic samples when we're studying these things for some other reason beyond talking about depression. So just to say it again, these are things across domains: psychological, social context, genetic, biological. These are examples of things that have high signal that seem to be statistically relevant or come up a lot in both the depressed non-autistic literature, but also just the general autistic literature, not specific to people with autism who have depression. So if these things are elevated in both of those populations, we should study those as a way to that co-occurrence within the autistic population, depression within people with autism. But another takeaway point here is that any one of these bullet points that we would pick to really focus on to intervene, first of all, it would be terrific to have any movement toward better interventions. So I'm not trying to dissuade anyone, but we know that these things interact. There's a dynamic process that they affect each other. So we have to sort of recognize that there are many contributors at play, and we can't just isolate one necessarily. Well, I don't know why my titles aren't coming up, sorry. So why does it matter how people become depressed? Why does it matter the pathway or the mechanism? Shouldn't we focus on the treatment once they're already depressed? And the answer to why it matters, how they become depressed, is the idea of treatment targets. So we have depression interventions in the general population. How can we make them work for people with autism? Why would we think that those general depression treatments will work for people with autism? We want to know, are there specific ways that people with autism become depressed? And then we want to target those ways when we're trying to intervene. So as you can probably imagine, there are very few interventions developed for the adult autistic community, and the few that do are primarily not focused on mental health. So we urgently need, both for adults and for children on the autism spectrum, we need to identify cognitive, social, and behavioral factors that might represent these treatment targets around which to build better interventions for depression in the autistic community. So in my lab, in the past decade, we have been really interested in the idea of repetitive thinking as a candidate treatment target. One, because we know that from the general population literature, the idea of rumination or passive negative thinking predicts and or maintains depression and a host of sort of related negative health outcomes. And we also know that restricted and repetitive behavior, sort of manifest, visible behavior, is a core symptom domain of autism. So to sort of bridge those 2 points, we need to study repetitive thinking. And it's harder to study what you can't see, obviously, but it really could be a key between the repetitive behavior of autism and the ruminative, repetitive negative thinking of depression. So that's where we are going in our lab. Again, just as a visual, if you start from a baseline of a person likely to have more perseveration or cognitive rigidity, when that lands on a neutral or positive focus, you might see that as special interests or strong, intense interests or preoccupations. But that same cognitive rigidity and perseveration can land on a negative focus, like life is unfair, or I'll never get a girlfriend. And that, when you're sort of spinning your wheels on those negative sort of self-talk or negative schema, you may be on a road to depression, anxiety, or just generally negative affect. Let's see, I am going to talk about this a little bit. So our lab in the Rowan psychology department currently focuses on studies of repetitive thinking in autism, and not just as it's linked to depression. So we're using behavioral, eye tracking, pupillometry, EEG methods to learn more about repetitive thinking in the autistic community more broadly, and how nuanced facets of that may be associated with physical, mental, or social behavioral health correlates in autism, both the good and the bad, actually. So not just depression, but are there parts of repetitive thinking that are associated with feeling good? Like, for example, repetitive thinking on your special interests. Is that a good thing in some ways, or a mix, sort of good in some ways and not so helpful in other ways? We're trying to learn about those sorts of things. We also study depression in autism more broadly, using both quantitative and qualitative methods to develop better depression measures of depression symptoms in verbally fluent autistic adults. We're using a nonverbal eye tracking task to learn more about mood in the autistic community with limited spoken language or nonverbal individuals. And we also have a couple of longitudinal studies of prospective predictors of depression symptoms. So that's what we're doing. I'm going to skip, and I'm actually going to skip some of these findings. Let me just check the time.
We have time. What you can do, we have until 9:30, and then we leave some time for question and answer. And depending on how much time is left, we can always go back to this content.
I think that makes sense. I mean, even though it sort of flows and I stuck it here, if you don't mind, I think I would rather talk about treatment first if we have sort of a mixed audience. And
yes.
If we have time or interest, we'll go back. I have other slides with more graphics about that make it sort of easier to take in about some of our research findings, and we either can or don't have to do those.
Very
Okay.
good.
So, and now yeah, okay. So let's see here. So now moving on to the treatment overview. Excuse me. I'm just gonna take a moment as we're switching topics. Okay, so let's see. In an ideal world, we would have a multidisciplinary care team with coordination of services across relevant systems, home, vocational, social, educational environments, etc. And we would also coordinate the treatment modality, the type of treatment you receive, with the patient's level of cognitive functioning and social emotional insight. We do need more data on how to best do that, how to actually tailor treatment type to these things, individual differences in cognitive functioning insight, to needs, interests, and values of the individual and the child and their family, and to biomarkers or individual profiles that do point to a mechanism. For example, potentially matching behavioral activation as a treatment for someone with extreme sort of anhedonia or lack of motivation, but maybe rumination-focused CBT for those who have high repetitive thinking. That's just an example. So we need to know, sorry, just to go back. So we need to know best or better how to tailor treatment type to those individual mechanisms that might contribute to depression in a certain person, as well as their values and their characteristics. Here's some common depression treatments that hold promise for adaptation to the autistic community. Cognitive behavioral therapy, CBT, is a highly effective treatment for depression in the general population when it is delivered well. So when people are actually trained to do it well, it seems to really work. We'll talk about some of these adaptations for using CBT for depression and autism in a second. We do have randomized controlled trials to suggest that CBT works to treat anxiety in ASD. We don't have very much data on depression as an outcome. But again, in the general population, it seems to work quite well. Behavioral activation, or BA, stems from that CBT science, and it focuses on treating anhedonia, or the loss of pleasure or interest that may come with depressed mood. And it does so by promoting activities that are sort of self-reinforcing. So sort of getting people over that hump to get back into activities that they once liked, and to try to use schedules and motivators to let those activities sort of take hold again as being intrinsically reinforcing. To my knowledge, behavioral activation has been largely overlooked in the ASD population. I think it's a really promising lead for us because first, this can be applied to less verbal populations. So it's not just, CBT is, works best for people who are verbally fluent, have some level of emotional insight, but behavioral activation, it can help sort of across IQ levels or impairment levels. Second, the reason that I think BA would be really helpful for us to know more about is because we do have data in the autistic literature to indicate that lifestyles with very low structure, so, for example, an autistic teenager with very few set obligations or activities, a lot of times that minimally structured lifestyle is associated with poor emotional health outcomes in people with autism. Let's see, there are a few small trials of mindfulness-based therapies that have reported decreased depression and anxiety in adults with ASD. Not much literature out there on this yet, but it's coming. I'm going to talk about ACT, acceptance and commitment therapy, in a second. And then in terms of pharmacological treatments, SSRIs are very commonly used in ASD for a variety to treat or target a variety of different behaviors. As far as I know, there's no RCT, no randomized controlled trial of efficacy specifically for use in treating depression in autism, although supposedly there is one such trial underway in the UK. We just don't have data from it yet. Okay, so that's just the general overview of things that tend to work from the general population literature. I'm not going to spend much time on cognitive behavioral therapy. Hopefully you have some background in it, but the gist is this idea right here that how we feel is actually directly related to our thoughts and interpretations of things that actually precede those sad feelings or depressed mood. So it's this thoughts, feelings, behavior kind of interactive schema. And I wanted to spend more time not on describing what CBT is. Sorry, I know I have lots of words on slides and you're also reading this in interpretation, so or translation, sorry, so I don't mean to skip so quickly, but we're largely going to skip past this to talk about modifications of CBT in people with autism, or for use in people with autism. So some ideas were suggested by Connor Kearns, an anxiety researcher in autism. She's interested in both anxiety, but also trauma. Now I think is very trauma focused in the autistic population. And she has sort of, she has a paper in 2016 that talked about focusing more on psychoeducation, not only more, but more slowly on psychoeducation within cognitive behavioral therapy when you're working with someone with autism. So, sorry, I'm going to go over this a little more high level, but I believe you have the translated versions of these slides. So hopefully you have some time to kind of digest this on your own. Another sort of broad level thing that Connor Kearns recommended was, so again, psychoeducation is learning to identify emotional and physical symptoms and sort of associated behaviors. So you first have an idea of what is going on in your feelings and in your sort of physical sensations and behaviors. She also talked about making things more interactive and possibly more technology-based within therapy. Whoops, sorry. And I also wanted to add Gloria Hahn, who recently moved to Vanderbilt University Medical Center in Nashville, Tennessee. She has a lovely paper in preparation right now about incorporating special interests in cognitive behavioral therapy, both to build engagement and rapport, but also as specific strategies for content delivery. So modifying your exposures, your rewards, your coping tools that are all part of CBT itself, modifying those to pertain to the person's special interest. So those are some modifications to keep in mind. I think that have show a lot of promise. Behavioral activation, I already talked about this more than I intended to on the previous slide, so I'm largely going to skip this. But again, this is that idea of getting people out and engaged in the world around them again, to let that sort of take hold as being self-reinforcing. And the thing I think is so interesting about behavioral activation is that it is focused on increasing both easy and pleasurable things, but not only easy and pleasurable things, also getting people more involved in challenging activities that will ultimately be very meaningful things for them to know or have learned to do or have taken on. So, and behavioral activation, like I said, we're not doing much by way of studying that, but I know Vanessa Ball is her married name, at Rutgers University, is starting to partner with Andrew Yehoda from Scotland, who has been doing most of the BA work that I know of in people with intellectual disability and some with autism as well. And I think Vanessa's interested in learning from him and starting that here. So I'm excited for that to come, at least for us, to the United States, but spread more broadly as well. Okay, so I want to stop for a moment. We've talked about these specific modalities for treatment, But what if one's own context is truly depressing? So here in the United States, among other places, depression itself is sometimes considered an affliction of the privileged, which means if you're in a place where you are, where you have sort of safety, financial security, things around you that allow you to, at that point, you might actually be able to focus on your mood versus just merely surviving. But people, of course, can become depressed, despairing, despondent, when the situation around them is truly objectively horrible or very difficult. And that might look like ongoing abuse, or it could be stressors associated with extreme poverty or war. And obviously, you can imagine there is no magic answer, but I sort of present here for consideration this framework that comes from a treatment modality called ACT, Acceptance and Commitment Therapy. I'm just going to read inside this box. So this is about kind of the guiding principles of ACT. Instead of struggling against distress, clients are guided to accept that some negative feelings are appropriate responses to certain situations, and yet that this appropriate distress should not prevent them from moving forward in their lives. So then from there, the goal is to accept the personal and situational hardships, but also commit to making necessary changes in their own behavior to move forward despite these hardships. I am not an expert practitioner in ACT, but I am very interested. I bring this up obviously for the situation in Ukraine. It's a good reason to, to stop and have this here. But I will say that for autistic individuals across the globe, many people experience their context and sort of the level of social mismatch or lack of social understanding or acceptance of neurodiversity as something that they can't get around or can't get through. And therefore, acceptance and commitment therapy, I think, might be another really important thing that we know more about within the context of treating depression and autism. That idea of an appropriate response to real, true hardships, and still the trying to find creative ways to move forward in one's own individual life. Even without a formal modality, even without having an ACT therapist that your child could go to or that you could refer your patients to, still each of us can strive to reframe our experiences and perspectives it's not easy, but in the direction of gratitude, growth, and hope. And this quote over here is attributed, actually, not attributed, I have heard him in interviews say this. This is Mr. Fred Rogers, who was a developmental psychologist who ran a very beloved children's show in the United States for several decades. And I heard him say on interviews, when I was a boy and I would see scary things in the news, my mother would say to me, look for the helpers. You will always find people who are helping. And that, I think, is an important sort of first step or example, I guess, of how we can try to help our children or help ourselves in kind of, just plugging along and reframing toward this gratitude and this growth. Okay, the other thing I wanted to talk about in this treatment section is actually about prevention of mood problems. I'm going to quickly click through some slides that I presented that are mostly about healthy living, structured time, social, basically these bullets up here. Some slides that I presented on a panel with Brenna Maddox and Ali Schaefer at the beginning of the pandemic. Here we're going to sort of switch over to those slides. And the idea is to take care of your mental health in advance by attending to these domains: physical, social, mastery, fun, and service. And these are things that we would try to incorporate in our daily lives. So for example, If you can, get outside every day, get daily exercise, eat healthy foods. If you have medications, remember to take them, get yourself on a schedule, get regular sleep. In terms of social things, create opportunities for yourself. If online is an option, you can use that. Get to know new people through shared interests to the extent that you can, and really focus on something a lot of people, at least a lot of people I know on the spectrum, have never, we sort of have these rote approaches to social interaction, but not that many sort of nuanced, deeper education for them about keeping your relationships healthy, about how to get around disagreements, what to do if you're feeling really upset with someone, that kind of thing. Let's see, mastery, developing new skills, things that are really that have to do with daily living skills, and sort of adaptive behavior, be able to accomplish things, even if that's checking things off of the to-do list. I know I love that. Every single day of my life is crossing things off my to-do list. And also balancing time for fun. Enjoy things for the sake of enjoying. Bring in some of that mindfulness. Create a list of options. So if you're not really feeling like it, kind of help yourself out by keeping track of what you have enjoyed in the past and choosing what sounds most fun in the moment then. And finally, I think this was the last one, service, contributing around you, and that could be in small actions as well, like, for example, helping a family member, as well as bigger things. Again, these were slides that came out of the beginning of the pandemic, when a lot of people on the autism spectrum had a lot, I mean, all of us in the, our whole, our sort of global community had a lot of anxiety around what was going on. And, parents and clinicians were reporting that this was particularly difficult for a lot of people, on a lot of individuals on the spectrum themselves. So we talked also about practice, tolerating uncertainty. That's hard at the best of times. It's really hard when there are uncertain times, but let that become a practice for you in building that tolerance to that, building flexibility, practicing moderation. That might be limiting screen time or limiting how much media you consume about what is going on around you. Practicing gratitude, we talked about already. I won't read all of these on this slide, but again, I hope that you do have these slides in translation, and that some of these things may be helpful as you interact with your children, if you're a family member, or with your patients and their families, if you are a health professional, or both. And then finally, that idea of just being gentle with yourself, that getting by is okay, and just getting by, and not really flourishing and thriving, but doing whatever you can, even if that means just getting by. In really difficult situations, that's enough. And this is a lovely quote from someone, from an autistic person himself, saying, like many of us, I'm being productive when I can, and perhaps most importantly, I'm being kind to myself when I cannot. So it's easy to list all of these things about healthy living. It's also very easy to fall short of these things in your daily life. But again, that optimistic mindset of, okay, just putting one foot in front of the other is enough. And tomorrow I have a chance to try those things again. And who are the people, look for the people helping, look for the good things, the little moments of beauty, the happy things, and just try to keep reframing to that. And again, this is also, this is all along that idea of prevention. The next thing, I'll check time one more time. Yep. The next thing I wanted to talk about is the idea of an emotion regulation toolbox. I tend to use this with all clients with depression and autism that I work with, even across ages. Sorry, I'm looking back at my notes here, and I wanted to say that basic healthy living stuff that we just covered, it is the most important first step, and it is also, those are hard steps. So just because those slides were pretty doesn't mean that getting good quality sleep or eating in a healthy way is easy for many families with autistic loved ones. And because it won't always be easy, it is important for people to have these be prepared with these strategies ahead of time. So the idea of the emotion regulation toolbox, I like to have my clients prepare personalized strategies ahead of time. I help them and we come up with these together. We pick domains. Here I have just 4 on the screen, but I also like to have sensory distress tolerance tools. There are other domains that might be specific to certain people that you would be doing this with. And you would kind of put this toolbox or this menu, you can think of it as a menu, together when you're feeling relatively well. So list what helps you relax, what helps you feel less anxious, what helps you feel more invigorated, what helps you calm or distract yourself from negative thoughts, etc. And then when you feel yourself kind of slipping down into that sad or empty or anxious kind of space, or negative mood states in general, or if you are a parent doing this with a child, if you notice that in your child, try to choose off the menu of things that you create that you already have on hand. You can choose based on preference, what you feel like most in the moment or what feels the most tolerable in the moment. But you could also, truly roll the dice and pick at random and kind of force yourself to try at least 3 strategies from your list for at least 3 minutes each. Something like that, where you're trying to get yourself to engage in things that have worked for you in the past. So again, these are general, but you'd want to be as specific as possible for yourself. You might include phone numbers of people that you can call when you're feeling down, places you can go that have beautiful views or happy memories for you, specific episodes of television shows that will make you laugh or YouTube clips that make you laugh, specific songs that usually work to change your mood. You can gather pictures of interesting things or special people. And again, this goes on and on. Sensory tools might be, set a timer to watch a ceiling fan spin for 5 minutes and then rate your mood again, or watch flowing water for 3 minutes and rate your mood again, or whatever sensory things are appealing in this particular person that you would be working with. Distress tolerance tools. A good place to go for this is the dialectical behavioral therapy literature, DBT. An example of that might be to stick your hand in ice water for a certain period of time, and that sort of safe level of pain can kind of distract from that psychic or emotional pain. So anyway, get creative and sort of personalize these, and recognize that different responses or different activities on your menu or in your toolbox might be more or less effective for certain situations. And so instead of choosing at random, I would still do that if someone doesn't want to try any strategies on the list. But in general, it would be great if you can kind of tailor to things that are things that might be most helpful for the particular problem. Mood in the minimally verbal population. This is not fair to have just one slide on this. We are working on this as well, measuring and then steps from there of what to do about or how to help with depressed mood in people with limited spoken language. I think in terms of the best we know at this point is not much, but again, just to rely on behavioral change when assessing, and again, think about those behavioral activation strategies and increasing self-help skills. And then alternative therapies like therapy animals, art therapy, things like that. That might also be something of interest in the in limited language populations as well. This is not a talk about suicidality, but we do know that suicidal ideation is pretty well, at this point, pretty well established to be higher in the ASD population than in the general population, in the autism population versus the general population. All I will say about it at the moment is just to go back to the thing I said before, which is to ask about it. We ask about it in our studies all the time because we are interested in mental health. And I can't tell you how many times it is endorsed in someone that we had really no concerns about ahead of time. So that we just ask it as a formality because it's part of the standardized protocol in our lab, and yet people will endorse things. So that doesn't mean you need to be extremely worried or, check them into the hospital. That is not, we're not trying to raise alarm. In fact, if anything, we're trying to calm people by saying, the best literature out there from the general population indicates that bringing up and asking about suicidal ideation is not associated with putting ideas in people's minds or increasing that ideation. So it's important to know about it so that you can support the person. I'm going to leave it there for a second so we have time to just go to this last part, this putting it all together in these next steps. So where do we go from here? How do we really make a difference? First, just to summarize, depression is concerningly common in autistic people. It has a negative impact on all kinds of markers, and people want help with this. People are asking for more research and more clinical resources for this. Assessment of depression in people with autism can be tricky because of that symptom overlap that we talked about, because of difficulty communicating about internal states, and because of our lack of validated measurement tools. But we talked about some sort of tips for the best we can do to get around that at the moment. Some treatments for depression show promise, but we need more research in these areas. I think it's encouraging that yes, there are differences, but more than anything, we're seeing depression is more alike across autistic and non-autistic samples than it is different, which we kind of expected. But so far, those potential mechanisms or contributors, which I didn't talk about in favor of talking about treatment more today, those potential mechanisms seem to work the same way across populations, the general population and the autistic population, but they just seem to be more prevalent in people with autism. So more negative repetitive thinking or more difficulty with feeling socially connected. But those all might be promising inroads and again, treatment targets like we talked about. So I'm on my final 2 slides right now. For next steps, we need better measures, better tools to measure and use in clinical research and clinical practice. We need to focus on vulnerable subgroups. We have a lot of data to suggest that gender and sexual minorities are at particular risk for depressed mood, depression, and again, are more prevalent in the autistic population than in the general population. Children and adolescents are getting some, but children really need attention and have depressed mood that, again, we often aren't attending to. We need to focus on diverse potential causal contributors, which we've talked about, but some of the specific ones I haven't mentioned are things like camouflaging or behaviors to sort of mask autistic features when out in the general community, and things like trauma. And we need to join together, so it's not just researchers or clinicians, but have more direct community involvement in multidisciplinary teams. And the very last slide that I want to present is that we need both a long game and a fast track. Long game meaning we do need to start this careful, thoughtful research for long-term solutions. We do need wide-scale social change toward more acceptance and respect for the autistic community. We also need things to happen faster. Wide-scale social change is not going to occur overnight or even in the next 5 years. And same thing for meticulous research. So we also need some band-aids or creative placeholders in the meantime. And some things that we think that might do is talking to clinicians about the fact that a lot of those mechanisms do seem the same. And we want those clinicians that know how to do treatments already that target those mechanisms. We want them to open that up and make those accessible to people with autism as well as their other clientele. We also want to build awareness to keep this on the radar, depression and depressed mood on the radar for families and healthcare providers. So more people are screening for this, more people are setting eyes on people with autism and asking about these things. So with that, I'm going to leave that there. I need both of those. And this is an acknowledgement slide. And obviously, thank you all for listening to a very long talk in a different language.
Very good. Thank you. Thank you. A big thank you for this very informative lecture. We've had many requests to cover this topic. So I'm glad that we're here and we have several questions. So I know some of them you might have touched on, but it will be good if you are willing to elaborate more. So the first question is that, what about DBT? This is a common thing that's happening right now. And for people who are not familiar with DBT, DBT is dialectical behavioral therapy. This intervention was developed by Marsha Linehan to focus on individuals with specific personality traits with a goal to decrease suicidal ideation and non-suicidal self-injury. So what about DBT in ASD?
Yeah, that's a terrific question. I think the only place I mentioned it in the talk, this was probably sent in as a question even before I got to this point, was that idea of in the toolbox, there are certain things that come from the DBT literature that we know are terrific in the moment coping and or distraction strategies for distress tolerance. So I think DBT has just a wealth of things that we can borrow in autism. For one reason, because a lot of it, this was created in large part to address emotional dysregulation in a borderline personality population. And emotion regulation is something, or dysregulation is something that we know is an issue in the autism spectrum as well, especially for children, but kind of across the lifespan and for lots of people on the spectrum. So I don't have specific, I guess my thoughts are, this is a terrific question. Yes, we need to bring DBT over. I referenced Gloria Hahn, who's a colleague, former trainee, but really colleague of mine now. She has done work she has done her own clinical work using DBT, and I think uses it a lot and is starting to incorporate it in her research as well. So look for her name. I know Carla Mazevsky does a lot with actual emotion regulation, and she does really beautiful work. So I think those are some of the places I would go to think about like pretty cutting edge work in the crossover. To in my practice, it's not as much a part of my research, but in my practice, certainly we borrow strategies from DBT all the time. So I think it's a wonderful inroad.
Very good. Thank you. The next question is about treatment of depression with comorbid obsessive compulsive disorder in individuals with autism.
Yeah, that's a hard question. Well, we know the overlap exists. So we know some people truly have both. So one thing I would say, that is not to, so I'm saying that up front because I don't want to dismiss the idea of it. But one thing I would say is, I think appropriate diagnosis is important because some people sort of collect an OCD diagnosis along the way, when maybe a lot of what they really have is autism and anxiety, and more general anxiety. So one thing I would think about is trying to really be sure what you're seeing is a true co-occurrence, which does exist. So if that's what it is, I guess my answer, I will try to formulate an answer from there, although I don't have a good one. But going back to that idea that some people, there is that kind of misdiagnosis, in which case we have better, I would probably go back to the autism literature for how to treat rigidity. And I would go to the anxiety in autism literature for treating anxiety in autism. And we have both of those literatures in a lot more abundance than we do literatures about true OCD or how to treat true OCD overlap or depression. Sorry, I don't know if that was probably very confusing, but I think the diagnosis is important because you have fallbacks if it's more of pieces of each of those. If it truly is OCD, I mean, I would to the extent possible, really try to find an excellent psychiatrist and an excellent cognitive behavioral therapist at the same time, and really approach it kind of with both of those modalities in mind. And actually, we could ask Dr. Harden for other thoughts on that more so than me.
Yeah, so let's, so my thoughts, I think what you were trying to say is that one of the first step to take when we think about OCD and ASD, to see whether these obsessive compulsive behavior are related to restricted repetitive behavior with rigidity, insistence of sameness versus OCD. Because as you all know, restricted repetitive behavior are very common as part of the diagnosis of autism, and sometimes the threshold to make the diagnosis of OCD is lower by some clinician, and that's how individuals with autism, they collect the diagnosis of OCD along the way. So because that will help identifying restricted repetitive behavior, because we have some approaches that will help us deal with rigidity or insistence of sameness, and will make our job as expert in the field of autism or clinician in the field of autism a little bit easier. Now, with regard to comorbid depression with OCD, outside the field of autism, that's one of the hardest group of patients to treat. And depression is one of the complications of OCD. So you might be treating somebody with OCD for 5 years, 7 years, and after multiple attempts and after a period of time, they end up developing depressive symptomatology. And that's when you have to be a little bit more aggressive in the treatment. And I agree, like identifying a very good cognitive behavioral therapist and a psychiatrist will be key, because from a CBT point of view, from a therapy point of view, CBT is your optimal choice. This is in the high functioning individual. And from a psychopharmacologic point of view, that's when you have to do more combination treatment by, for example, using an SSRI in combination with an antipsychotic to be able to treat this comorbid condition. So it's a challenging situation, even when you don't have an autism spectrum disorder. But there are treatments out there for comorbid depression and OCD. Thank you.
Thank you.
Next question, it's very specific, but we'll try to generalize that. We'll try to avoid answering specific questions or questions about specific situations. So what are the thoughts about treating individual with autism in this situation, non-verbal or minimally verbal child with RFID, which is the restricted feeding disorder? I know it's outside the depression, but I don't know if you have any thoughts about that.
I saw this ahead of time on the screen, and I will say I don't want to say too much about it because I don't feel this is not my area of competence, so I don't want to say something and misspeak and mislead you. I would guess that there would probably be a strong behavioral and behavior analysis and sort of functional behavior or applied behavior analysis kind of approach to this, but that would be something I would hope you would hear from a different health professional and not just from me. I mean, that's my guess of probably the first route to go if you haven't spoken to someone, but otherwise. The other thing I would say about this question, there was a tag on of the symptoms worsened after relocation. Yeah. I guess I would say, and I will even jump down to the next question that is talking about an adult client, autistic with intellectual disability, minimally verbal, and has a cancer diagnosis. So in both of these cases, there is something sort of new in that person's environment, like this child relocated, and there's all the stressors that come with a move, with feeling sort of not at home in your current environment with all these transitions. And certainly the person who is kind of making sense of a cancer diagnosis and all of the medical interventions and invasive kind of medical things that will happen to that person. In both cases, I would say, there are going to be specific therapies, physical or mental health therapies for each of these main things, the cancer itself and the food restriction itself, but also maybe as a supporter, as a family member or clinician supporting that person, to also think about that larger context. So not just about the eating restriction, not just about the cancer diagnosis, but also what are ways to kind of improve or build in times for joy in life, or times for to think about things that are loved, enjoyed, or had been enjoyed as you partake in them. That I think is really important. The same thing with the child relocating, in addition to concentrating on food itself, can you also concentrate on, or can you also add building that sense of security and starting to get that child to have, kind of positive connections with that new place as well. Because I think some of those things can be kind of context, or at least supported by other types of focus for your context itself, and not as much, not only kind of hyper focus on the presenting problem.
Yeah, additional thoughts is that I think this has come up previously with the kids or adults with autism who they are relocating, and during a time of war, relocation is not a smooth process. It's something that happens very abruptly for multiple reasons. Is a common observation, and individuals with autism as well as kids, and even us as an adult, we react differently to change of environment, and this relocation could be a significant stress on some of us. Imagine a kid with autism who's used to have some of his of their routine on a regular basis, and here we go, you kind of move them to a different environment where they cannot see the same garbage truck at the same time, or they cannot see the same store at the same time. So usually in this situation, something to think about, whether this change in eating habits, whether they are associated with other symptoms. If it's only isolated to food, then on to eating behavior, then you can try to address that. But if there are additional symptoms associated with it, let's say sleep disturbances, decreased interest, decrease in concentration, more mood lability, so then you may be talking about change in eating habits that are associated with depression, and the treatment might be a little bit different, and it's just a change in eating habits. So that's something to keep in mind when there is a change in eating habits. Very good, thank you. Next question is that any specific red flags regarding the onset of depression and anxiety in high functioning kids with autism? What's your experience with the emergent or the first few symptoms that you could that a child could experience as a manifestation of a depressive disorder or an anxiety disorder?
Yeah, well, I will say up front that my research tends to focus more on adults. So it's been a while since I have worked with kids directly, so I apologize for that. But from what we know in general about depression and autism, and about children with autism, I think a couple of things I would probably be on particular watch for. One is increased irritability, and that might also look like frustration, things not being in control, or in that child's sort of ability to change control, you wanting to have more control over things, and more frustrated, irritable response to that not being possible. So I would look for irritability. I would also definitely keep an eye out for withdrawal, especially withdrawal that's additional to baseline. A child who you know, if you had a parent's phone or iPad just sort of withdraws and hides and is on the phone, or you find that child just kind of sitting away from people, if that is not typical baseline for that child. So I definitely the withdrawal and the irritability. And then again, going back to the idea of certain exacerbation or kind of increase in autism symptoms at those times. Not all kids have this symptom as clearly, but sometimes you really do see differences in the type of special interests that do either have more of a, you know, sort of a dark or a scarier focus, or just more intensely, you know, just wanting to surround yourself with that only, being even more difficult to transition off of the special interest, things like that. So those are some of the things. I know we discussed some of those in the presentation, but I would go back to kind of those as being, at least in young school age kids or older preschoolers, I would think that those are some of the things you would also be looking for as kind of first symptoms.
Yeah, thank you. Just to add the way we think about it, because we get a lot of consultation regarding, okay, emergent depression, emergent anxiety, when do we treat, when do we get concerned about? Once you notice that any change in behaviors, whether are related to depression and anxiety, is affecting the functioning of the child, not participating in activities, not wanting to go to school, not wanting to go to a birthday party, that's when you have to be concerned and ask for help. And this can be manifested in about 1 million different ways. That's why, like, whenever anything affects functioning, the normal function of the child, that's when you have to seek help. Very good. Next question. I think the fun part of this is to try to answer the question. And when you think you've heard it all, you realize that, no, you're wrong. There is a different question. There is a new question. So that's what's the fun part here. So the next one is about different types of depression. People have tried to characterize depression, different types of depression. Based on your experience and your work, even in adults with autism, are there any types that are more prevalent than others?
Yeah, so this I have more kind of data to back up, and it is adult data. So I will say that I don't know if this answer would be different in children. But in our adult data, we were somewhat surprised to find out that there didn't seem to be an autism-specific presentation of depression to the same extent that you would see in the general population. And again, general population is mixed, and there's a lot of other kinds of conditions that are, you know, that are pockets of the general population. So compared to just sort of the general depression literature on large samples, you know, we know that there are people who have more of an irritable or sort of anger and anhedonia kind of presentation, some people that have more of that kind of sadness or high emotionality, some that are really high on anhedonia where it's just a numbness or a checking out. We weren't seeing different level, we weren't seeing sort of, let me back up. In our autistic adult samples, both in very large, or for us, very large samples of, you know, like 800 or more autistic adults and online survey research, or in our smaller samples of, you know, 100 people, but with lots of careful clinical phenotyping data, across both of those methodologies, we weren't really seeing a different or a single type or a more salient type kind of emerge. So in that case, it doesn't seem like there was a specific autism presentation of depression. We did talk a little bit about symptoms or ways of describing it that might be different in patients with autism. So yes, there were those, but we were just mostly seeing similarities in depression, even if it was, you know, across these different types. In terms of it, just in case this person was also asking about things like bipolar disorder or sort of other kinds of things that do, other kinds of depression in some ways, that that you can probably imagine is not as prevalent in autism as depression, nor is it as prevalent in the general population as general depression is, but it certainly exists. It is there. We have seen it. And that I would say, again, I know this question wasn't about what to do about it, but that is another one that you would definitely want to have a psychiatrist on board in addition to some of these behavioral therapies that I was talking about. So I would not, when we start to see mania or sort of psychotic features in depression, I don't think my talk really sort of covered that in depth, but that is at a time where you absolutely want psychiatric oversight as well.
Very good. Thank you. Because the way to look at depression in terms of different types of depression is whether related, it's a major depressive disorder, recurrent, or single episode, or a mood disorder as part of bipolar disorder. There's also, so that's one way to classify the depressive, but there is the other way, which is it's old classification with regard to like the melancholic depression, the depression with psychotic features, or the neurotic depression when people get worse a little bit more at the end of the day. Very good. Okay, another question that is very frequently observed in clinical practice is, how do you differentiate between adolescent anhedonia and the desire to shut down or stay away from your parents and being in your room as an adolescent versus clinical depression?
Well, I don't have an answer for you. That is another, this is an audience who clearly has thought about this a lot and or has experience, because these are very good questions and tough questions. I don't have a great answer, but I will kind of go back to what Dr. Harden had said about functional impairment. So I think in that question, we were talking about what are some early signs. We talked about early signs, and then he had added this kind of comment of, when you see these early signs start to move into actually having impairing functional behavior, that's the time you want to move. And, by that point, you want to make sure you are starting to seek intervention. By that point, at kind of the latest, or maybe, that would be a marker for people. I think similarly, yes, there's some social withdrawal. There's some, let me put it like this. There is some sort of behavioral aspects of adolescence where kind of transitioning to being more peer focused or more self-focused versus connected with the family. That is part of, kind of normative developmental stages. However, anhedonia is not in and of itself a diagnosis, but it is a trait that, sorry, and I'll back up. It is, yes, it is a variable trait in the general population. So there are some times and contexts and times of life that we have more or less anhedonia, but I already am thinking of anhedonia as a bit of a symptom and not just typical adolescence. So wanting to spend time in your room listening to music instead of being with your family, that might be just being an adolescent. But if it's truly anhedonia, which is defined by taking less pleasure in things than you previously took pleasure in, if there are not things that kind of creep in to meet that and become the new thing that person is interested in, if it's just truly a lack of pleasure in general, to me, that is a symptom of depression. That doesn't mean that depression is there, but that is one sort of symptomatic thing. It's not just, oh, I want to hang out in my room instead of with my mom. It's also, I don't like things. There's nothing I like. There's nothing that feels exciting to me right now. So again, doesn't mean that adolescent has depression, but I would think that if it's truly a lack of enjoyment or a lack of pleasure where there had been pleasure previously and nothing new to sort of replace that, not a new focus, but a true sort of lack of any thing to replace that in any pleasure, I would already be keeping a close eye on that adolescent, because that seems to me different than mere behavioral withdrawal. And just, kind of wanting more privacy or more time away from the family or with friends. What are your thoughts, Dr. Hardner? Are there things that you would add?
I go back to what we talked about is functioning. If it's affecting their schoolwork, their grades are dropping, or they are not socializing with their friends, that's when I become concerned. If they are isolating from family members, especially from the parents, this is expected during adolescence. But that's why I usually ask the question, grades, and are they still going out with their friends? Are they still communicating with their friends or not? We have 4 minutes. I'm going to try to squeeze 2 questions in. The first one is, can irritability and sensory overload get better by itself over time?
Sorry, and I'm just reading, especially if it was mistaken as symptoms of autism itself and not autism and severe depression. Okay. Yeah, I'm not sure if you have different experiences with this, Dr. Harden, but yeah. Because I largely work with adults, I do see a lot of movement from both what these adults and their caregivers report that they were like as children, but also from the children that I worked with primarily in the beginning of my career. Adults look different. So somehow along the way, you got to that difference. And I do think I think that's true even of teens. So I think I know we're trying to be short, so I would say I think that is hopeful. I'm not saying don't get help or that it will just go away on its own, but if the actual question is, does it ever get better just with development over time? I do think that, we do see evidence of that for some subset of children for sure.
Yeah, I want to echo that fortunately, some of the sensory sensitivity, sensory issues and irritability, they do get better over time. And it's supported by the fact that when you follow up individual over a longer period of time, they are less likely to take medication or receive medications when they are adults as they were adolescents or young kids. But this should not mean that you should put up with this, especially if it's affecting the safety of everyone.
And I will actually just jump back in really quickly to say, when I read this question, that sort of signals in my mind, again, that idea of emotion regulation and coping skills. Because when we talk to adults, it's not that they don't have sort of adverse responses to things in the sensory world. They just have more of a broader view of how important or how big a deal those are in the grand scheme of things. Does that make sense? So we still see adults say like, I hate it when people in my household use, silverware as utensils instead, I want them to use plastic utensils, but they don't have that sort of, and they might even have mild irritability, but they don't have kind of a meltdown over it, or it's not something that is so bothersome that it affects their work, their, relationships, etc. So I think that is really helpful. Sorry, I don't know if that here, you want one more, or I don't know if I talked over your second.
No, that's okay. No, that's the last question. I think it's related to a 17-year-old. Again, we don't want to try to avoid answering specific questions, but in general, in terms of what's the difference between a diagnosis of burnout versus depression, especially when the symptoms are not associated with suicidality?
I haven't read this whole question, so I apologize if this wouldn't work for this particular case, but since we're going general, where you remember self-report matters, right? So if you do have the verbal or the intellectual or the insight kind of ability in this 17-year-old, that is, I think, old enough to really talk to that person about, look, these are what we wonder about for you. Even to the extent of giving them information or literature about autistic burnout or camouflaging. This is what people call this. This is what it is. This is what depression is. We're not really sure what's going on for you between these two, but we want to make sure we're getting you the help that you need, if it's this or if it's that. What are your experiences? And that doesn't mean that person can answer the question easily, but starting to bring them into the conversation, I would definitely vote for that. because we have found that where people are capable of self-report, still a lot of times it's overlooked, and it makes a big difference when you can include it.
Very good. Thank you. Thank you. Thank you. Thank you for everyone for their
Thank
attendance. Yeah, and thank
Thank
you
you all.
for the great question. And Dr. Gotham, thank you for this informative lecture. I know there was the research part that we didn't get to cover. However, we have other forums that we have other forums here at Stanford. We might send you an email depending our schedule to invite you to give a lecture that could focus a little bit more on your research in depression. So
I would
it will
love
be a
to,
different
and
forum.
thanks for this opportunity to present here. Thank you all. And
Very
thanks,
good.
Dr. Harden and the Stanford team.
You're welcome. You're welcome. Thank you, everyone. We'll see you next time. Okay. Bye-bye.